Welcome to the deep dive. Today, we're jumping into something that sounds simple but can get pretty complex: anemia in adults.
It's a really common clinical problem.
Yeah, exactly. We've been looking at some great clinical resources, mainly up to date, and our goal today is to, well, pull out the key ideas about how doctors figure out what's going on with anemia.
Without getting totally bogged down in every single detail.
All right. We want to give you a solid foundation. So we'll talk about what anemia actually is based on blood tests, why those normal ranges can be a bit flexible.
Things like blood counts, other initial tests, and then different ways to sort of categorize it to figure out the cause, like looking at red blood cell size or how the bone marrow is responding.
Perfect. So let's start at the beginning. What exactly is anemia, technically speaking?
Well, basically, anemia means there's a reduction in your red blood cell measurements. We look at the complete blood count, the CBC.
Okay.
And specifically, we're looking at the hemoglobin concentration, the hematocrit, or the red blood cell count itself.
But you said some are more important than others for diagnosis.
That's right. Usually it's low hemoglobin or low hematocrit, or both, that really flags it as anemia. Those are the primary indicators we use.
Okay, so what are those levels? What numbers actually trigger that flag?
Generally speaking, for adult men, it's a hemoglobin below 13.5 grams per deciliter, or you might see hematocrit below 40%.
And for women?
For adult women, the general cutoffs are a hemoglobin below 11.9 GDL, or a hematocrit under 35%.
But you mentioned these aren't set in stone.
Exactly. These are general guidelines. Clinical judgment, looking at the whole picture for the individual patient is absolutely crucial. These numbers aren't rigid lines.
Right, because what's normal for me might not be normal for someone else.
Precisely. Those reference ranges, they can shift. Factors like your age, your sex, even where you live, altitude makes a difference. And things like smoking prevalence in a population can affect the average ranges.
Interesting. I've heard of the WHO criteria too, the World Health Organization ones. Are those different?
They are slightly different, yeah. Hemoglobin below 13 for men, below 12 for women.
Yeah.
But it's really important to know those were originally set up for international nutrition studies looking at populations. They weren't meant to be the absolute gold standard for diagnosing an individual person.
So there's some natural variation, some wiggle room in these normal ranges?
Definitely. Think about how normal ranges are usually calculated.
Yeah.
They often represent the middle 95% of a healthy group. That automatically means 5% of healthy people fall outside that range.
Ah, okay.
And here's something really interesting we see consistently. Average hemoglobin values tend to be lower in Black Americans, usually about 0.5 to 1 gram per deciliter lower compared to white Americans.
Yeah, I've read about that. Do we know why?
Well, the exact reasons are still being explored. It's likely a mix of things. Health disparities unfortunately play a role. There might also be a higher prevalence of certain genetic factors like alpha thalassemia trait in people of African ancestry. Or maybe other genetic or environmental things we just don't fully understand yet. And this is key, the diagnostic thresholds we use for anemia. They're the same for everyone, regardless of race or ethnicity.
Got it. And what about getting older? Does our baseline change as we age?
It's a great question. Yes, it seems to. While the average hemoglobin in older adults, say over 70, is often still within the usual range, the lower end of what we see in that age group is often below what we'd consider normal for younger adults. This might be linked to other health issues that are more common with age, like chronic kidney disease.
So you don't just set a lower normal for everyone over 70?
No, the preference is really to evaluate each older person individually, look at their hemoglobin in the context of their health, rather than just applying a blanket lower limit for the whole age group.
Makes sense. So hemoglobin and hematocrit are the main focus. What about the simple red blood cell count? Does that tell us much?
Usually the RBC count tracks along with hemoglobin and hematocrit. If one is low, they're all low. But there are exceptions, and they can be important clues, like in severe microcytosis, where the red cells are really, really small, like in thalassemia.
Right.
You might actually see an increased RBC count, even though the person is definitely anemic based on their hemoglobin. So high RBC count with low hemoglobin can point you towards something like thalassemia.
That's fascinating. I also saw RBC mass mentioned somewhere. Is that used clinically?
Yes.
Yeah.
In research, you can define anemia by a reduced total red blood cell mass, measured using special blood volume studies. But it's complicated, pretty impractical for everyday clinical use. Hemoglobin and hematocrit are the workhorses.
All right, so we've kind of nailed down the definition and the nuances of normal. What about things in real life that can push those hemoglobin or hematocrit numbers around, making it harder to interpret? Things that lower them.
Yeah, there are definitely situations to be aware of. For lower values, think about intense physical activity.
Hmm.
Endurance athletes, for example.
Really?
Why's
How?
that? A few reasons. They can get what's called dilutional anemia because their plasma volume expands. They're also prone to iron deficiency and even something called March hemolysis, where red cells get damaged just from the repeated impact, like running.
Wow. Okay. What else?
Pregnancy is a big one.
Yeah.
A pregnant person's red cell volume actually goes up, but their plasma volume increases even more. So, relatively speaking, the hemoglobin and hematocrit drop.
Is that dangerous?
Usually not. It's often called physiologic or dilutional anemia of pregnancy. As long as the hemoglobin stays above certain levels for each trimester, it's generally considered normal. And like we talked about, just getting older can be associated with slightly lower baseline values too.
Okay. And on the flip side, things that might make the numbers look higher than they should, maybe masking anemia?
Oh yeah, definitely. Smoking is a classic one.
How does smoking affect it?
The carbon monoxide from smoke binds really tightly to hemoglobin, more so than oxygen. This can lead to increased hemoglobin, hematocrit, and RBC count, even though the body isn't necessarily getting more oxygen delivered effectively.
Interesting. Any medications?
Yes. Things like androgens or certain diabetes medications called SGLT2 inhibitors can raise levels.
Mm.
Also, hemoconcentration.
Meaning?
Like when someone's dehydrated or lost a lot of fluid, the blood gets more concentrated, so the hemoglobin and hematocrit look relatively high. The true underlying anemia might only show up once they get fluids. We see this in burn patients sometimes.
Crucial point.
And finally, living at high altitude. The lower oxygen levels trigger your body to make more red blood cells, so people living high up naturally have higher hemoglobin and hematocrit.
Got it. So the basic CBC gives us the first alert, but you mentioned other info within that same test helps figure out the why, the red blood cell indices.
Exactly. The indices give us more detail about the red blood cells themselves, their size, how much hemoglobin is in each one, how uniform they are. The most useful ones are usually the MCV and the RDW.
MCV and RDW. Okay, break those down for us.
Sure. MCV stands for mean corpuscular volume. It's basically the average size of your red blood cells.
So big cells, small cells.
Right. It helps us classify anemia. Is it microcytic, meaning small cells? Normocytic, normal-sized cells, roughly the same size as the nucleus of a lymphocyte on a smear? Or macrocytic, large cells?
Okay, MCV is size. What's RDW?
RDW is red cell distribution width. It measures how much variation there is in the size of the red blood cells.
So are they all the same size or lots of different sizes?
Precisely. A low RDW means they're pretty uniform. A high RDW means there's a lot of variation, some small, some large. We call that anisocytosis if you see it on a blood smear.
And what does a high RDW suggest?
It can pop up in lots of different anemias. Iron deficiency, B12 or folate deficiency, certain bone marrow disorders like MDS, even after blood transfusions because you're mixing different cell populations. Looking at the actual blood smear under a microscope often helps make sense of a high RDW.
Okay, so size and size variation are key clues. Now, what about reticulocytes? I remember those are the baby red blood cells.
Exactly right. Reticulocytes are the immature red blood cells, fresh from the bone marrow factory. Counting them gives us a really good idea of how fast that factory is churning out new cells.
How are they reported?
Usually as a percentage of total red cells, or sometimes as an absolute number per volume of blood. On a smear, they look a bit different. Maybe a slightly bluish tint, often a bit bigger than mature cells, maybe irregular shapes, and they don't have that pale center.
So if the reticulocyte count is high, does that mean the bone marrow is responding properly to the anemia?
Generally, yes. If someone's anemic, a high reticulocyte count suggests the bone marrow is recognizing the problem and trying to compensate by increasing production. A healthy marrow can actually boost production about 5 times normal in adults.
So you'd expect to see high reticulocytes in certain situations.
Definitely. Often high in hemolytic anemias, where red cells are being destroyed too quickly, or after someone has had significant bleeding. The marrow kicks into high gear.
But it's not always straightforward interpreting the count.
No, you have to consider the degree of anemia. A reticulocyte percentage that seems normal in someone without anemia might actually be way too low for someone who's significantly anemic. Their marrow should be working harder.
Right. I think I saw something about correcting the percentage. Sounds complicated.
It can be a bit, yeah. The issue is when anemia is severe, These young reticulocytes sometimes get pushed out of the marrow earlier than usual, and they might circulate for longer, maybe 2 or 3 days instead of just one.
Ah, so the percentage might look higher than the actual production rate.
Exactly. It can overestimate the true production. Sometimes people calculate a corrected reticulocyte count, or something called the reticulocyte production index, which try to account for the severity of the anemia and that longer circulation time.
Is there an easier way?
Often, just looking at the absolute reticulocyte count avoids needing those corrections. It gives a more direct measure of how many new cells are being made per day.
Okay, that simplifies things a bit. So we're building this diagnostic picture with lab tests. How does this actually relate to how a person feels? What drives the symptoms of anemia?
Well, the symptoms really boil down to the body's tissues not getting enough oxygen. And oxygen delivery depends heavily on the amount of hemoglobin you have, which, like we said, is reflected in the hemoglobin concentration, hematocrit, and RBC count.
Because hemoglobin carries the oxygen.
Right. Each gram binds a certain amount. But it's not just about the amount of hemoglobin.
Oh, what else matters?
How well the hemoglobin holds onto and releases oxygen, its affinity, also the total blood volume, how well blood is actually circulating and reaching the tissues, perfusion.
So even if hemoglobin is low-ish, other things could make symptoms better or worse.
Absolutely. For example, things that make hemoglobin release oxygen more easily to the tissues, like a slightly lower blood pH, or more of a molecule called 203-BPG in the red cells, or even a slightly higher body temp can actually help compensate.
And things that make it worse.
If your overall blood volume is low, even with a decent hematocrit, oxygen transport suffers because perfusion is poor. Or if you have other conditions messing with circulation, like low blood pressure, constricted blood vessels, poor heart function, blockages in arteries, those will all make anemia symptoms worse because the oxygen just can't get where it needs to go.
What about how fast the anemia develops? Does that make a difference?
Huge difference. If someone loses a lot of blood suddenly, their hemoglobin and hematocrit might look normal right at the beginning.
Really? Why?
It takes time, maybe 36 to 48 hours, for fluid to shift from the body tissues into the blood vessels to compensate for the lost volume, or for IV fluids to dilute the remaining blood. So initially, the concentration looks okay, but the total amount of red cells is down.
So the early symptoms aren't really from the low red cells yet.
Often, in acute blood loss, the immediate symptoms feeling faint, rapid heart rate, are more from the low blood volume, the hypovolemia, and the drop in blood pressure, rather than the lack of oxygen carrying capacity itself.
That's a really important distinction.
Yeah, contrast that with anemia that develops slowly, gradually, like often happens with iron deficiency or B12 deficiency. The body has time to adapt.
How does it adapt?
Blood volume might increase a bit. Tissues get better at pulling oxygen out of the blood. These compensations mean someone might not feel symptoms until their hemoglobin is actually very, very low.
So slow and steady is less dramatic symptom-wise.
Generally, yes. A rapid drop in red cell mass, like from a big bleed or sudden hemolysis, where those compensatory mechanisms don't have time to kick in, that's usually much more symptomatic at any given hemoglobin level compared to a chronic, slow-developing anemia.
This is all fitting together really well. So, okay, a clinician sees a patient, confirms they have anemia based on the CBC. What are the general game plans, the strategies for figuring out the cause?
It's really about categorizing things. You
Yeah.
take the patient, look at their whole picture, and try to figure out which categories of causes are most likely. This involves looking at their clinical features, age, sex, other medical problems, and combining that with the CBC results, especially those red cell indices like MCV we talked about, and the reticulocyte count.
So it's like putting different pieces of evidence together.
Exactly. Experienced doctors are usually thinking about several ways to classify it at once. Common approaches are, what's the overall clinical picture? Is there obvious bleeding? Then what's the cell size, microcytic, normocytic, macrocytic, based on MCV? And how is the bone marrow responding? Is the reticulocyte count high or low?
They're juggling all those things.
Pretty much, yeah,
Yeah.
considering them all together. And sometimes the pattern just jumps out at you. Like if the CBC shows pancytopenia, meaning low red cells, white cells, and platelets, that's a big red flag for a serious bone marrow problem needing urgent evaluation.
Okay, let's dig into that initial evaluation. What specific information are doctors trying to gather right at the start?
Well, first, any obvious clinical clues. Is the patient actively bleeding? Do they have a condition known to cause poor nutrient absorption? Then, a very careful medication history is vital, plus knowing all their underlying medical conditions, because so many things can cause anemia.
Right. And looking closely at that first blood test.
Yes, looking for those flags on the CBC and the basic chemistry panel. Are other cell counts low too? Is the white blood cell differential weird? Are the red blood cells funny shapes? Any signs of kidney or liver trouble? And like we said, MCV cell size is critical. And the reticulocyte count, telling us about bone marrow production.
What about asking the patient questions?
Oh, absolutely essential. Family history is important. Any inherited anemias like sickle cell or thalassemia in the family. Then digging into potential acquired causes. Diet, recent travel, infections, any history of bleeding, obvious or subtle. How long have they felt unwell?
Anything else symptom-wise?
Asking about symptoms that might suggest hemolysis, red blood cell breakdown. Things like dark urine, yellowing of the skin or eyes, jaundice, history of gallstones. Or did the anemia start after exposure to certain drugs or foods like fava beans? Also, any symptoms pointing to kidney or liver problems or an enlarged spleen. And again, how fast did the symptoms come on? Suddenly or over months?
So beyond that initial CDC and Reddit count, what other basic labs are usually done for someone with unexplained anemia?
Typically a chemistry panel to check kidney and liver function creatinine, liver enzymes like ALT, AST. If hemolysis is suspected from the history or the high Reddit count, then specific hemolysis labs are ordered. LDH, bilirubin, haptoglobin are common ones.
And looking at the blood smear.
Looking at the peripheral blood smear under the microscope is always desirable. Its immediate availability might vary, but it can provide invaluable clues about red cell shape, size variation, and even find abnormal white cells or platelets. It's absolutely critical in some situations.
It really sounds like you need to pull all those threads together, the history, the exam, the labs.
Absolutely. You have to synthesize the lab results with the clinical information to start narrowing down the possibilities. Depending on what that initial picture looks like, you might skip certain tests or add others. For example, a young woman with obvious heavy periods and small red cells, microcytic anemia. You'd probably jump straight to iron studies.
Makes sense. Now, this sounds like a lot for a primary care doc to handle sometimes. When should they think about sending the patient to a hematologist, a blood specialist?
Yeah, there are definite times for referral. Any kind of hematologic emergency is number one. That includes things like severe pancytopenia, finding immature cells called blasts on the smear, or pancytopenia happening alongside signs of hemolysis, clotting, or bleeding. Also, if you see those fragmented red cells, schistocytes, suggesting something called microangiopathic hemolytic anemia, that's an emergency referral.
What about less urgent situations?
Diagnostic uncertainty is a big one. If the anemia just doesn't make sense after the initial workup, or the labs are normal or unclear, or an older adult with multiple low blood counts where B12, folate, and copper levels are normal, that needs a closer look. Any other reasons? Definitely, if specialized tests are needed, like a bone marrow biopsy or complex flow cytometry, genetic testing for inherited conditions, or special scans looking for things like lymphoma. Anemia happening with weirdly high white cells or platelets also warrants referral. Known or suspected hereditary anemias.
And what about treatment needs?
Yes, if the patient needs treatments that are typically managed by hematology, like IV iron infusions, certain immunosuppressants, or other targeted therapies. Also, severe iron deficiency that isn't getting better with iron pills or happens late in pregnancy, or if the person just can't tolerate oral iron.
Yeah.
Any confirmed hemolytic anemia, or if there's a suspicion of chronic leukemia or a myelodysplastic syndrome, MDS, those all generally need a hematologist's input.
This has been incredibly helpful, really walking us through that initial process. Can we just quickly recap the absolute key takeaways?
Sure. So we defined anemia using hemoglobin and hematocrit,
Mm.
but stress that normal ranges vary based on age, sex, altitude, and other factors, so clinical context is key.
Right.
We talked about the red cell indices, MCV, telling us about size, microcytic, normocytic, macrocytic, and RDW, about size variation as crucial first steps in classifying the anemia,
And the reticulocyte count.
as that vital indicator of whether the bone marrow is responding appropriately or if there's a production problem. And maybe the biggest point is that you have to integrate everything, the patient's story, the physical findings, and all the lab results to figure out the underlying cause.
And really hammering home that anemia isn't the diagnosis itself, it's a sign. It could be something straightforward, or it could point to something complex needing specialist care.
Exactly. Hopefully, understanding these basic steps empowers you, the listener, to have better conversations with your doctor if this issue ever comes up.
Absolutely. It's pretty amazing when you think about it how these, fairly standard blood tests can open up such a complex window into our body's health and how it tries to compensate. Definitely makes you more curious about hematology and diagnostics. Thanks so much for this fantastic deep dive today.